Thank you everybody for joining us. I'm really excited. You're here for the Spinal Injuries, What Attorneys Need to Know as part of the High Rock Expert Series. So let's go to the next slide. And before we get to our esteemed guest, I just wanted to tell you, so I'm Dr. Amy Fogelman, and I am honored for you guys to be here tonight. I'm the founder and CEO of High Rock Experts. I have worked for 2 decades caring for patients at Harvard affiliated practices in the Boston area. And that led to me creating what was MedLaw Consulting and started, and it's now called High Rock Experts. And we have a core mission to provide ethical and credible expert reviews. And we've matched over 500 experts to attorneys across the US. And in 2020, we took this a step further by creating High Rock Academy, which was designed to empower medical professionals with the skills needed to become credible experts themselves. And so today, I'm really excited to be introducing you to one of our Academy graduates, Randi Rasberry, who is going to share her insights with you shortly. So we're going to do the introduction. Randi's going to present, and there will be time for you all to ask questions. What I'd like you to do with the questions is just to put those in the question and answer form, and stay until the end because I'm going to be sharing an announcement and a bonus for you. So Randi, you can take it away.
All right. Thank you so much, Amy. Hi, everyone. Thank you so much for joining this evening. My name is Randi Rasberry. I'm a physician assistant and a neurosurgery expert witness. So the conversation that we're going to be having today is going to be involving spinal injuries, particularly as they pertain to your practice and your clients. So I'm going to tell you a little bit about me. I'm going to go over some spinal anatomy basics, some common spinal injuries that you're likely have already come across multiple times in some of your clients, some physical exam findings that I think will be important for you to be able to notate in their medical records, some radiography tips, and a sample case to kind of wrap it all together. And then at that point, I'll open the floor for any questions that you might have. So a little bit about me. My name is Randi, like I said, and I'm actually from Louisiana. I live in New York now, but I went to LSU for undergraduate and got my master's at LSU as well. Go Tigers. So I have about 8 years of neurosurgery experience and experience in neurocritical care, vascular neurology, otherwise known as stroke, and pediatric neurosurgery. I have been the first assist in over 1,000 cases, probably around 11 or 1,200 at this point. And what that means is that I not only take care of patients and therefore your clients before and after surgery, but I'm involved in surgery as well. And I'll show you some fun pictures of that here in a little while. I sort of fell into, medical legal expert work after practicing for a while in private practice and seeing a lot of spinal injury. I was asked to weigh in on a couple of things with some attorneys that I worked closely with, and I've sort of built my practice from there. So we're going to start pretty, generic. We're going to first go over the spinal column or the spine. It serves 3 main functions, the first being protection of the neural elements. So the spine, the bony elements of the spine at least, are there to protect the spinal cord and the nerves. The spine also allows us to move and have fluid movement, and it also provides structural support and posture for our bodies. A little bit of basic anatomy of the spine. It's divvied up into 4 segments. So you have the cervical spine or the neck, you have the thoracic spine, which is sort of the mid back, the lumbar spine here, which is the low back, which is where you're going to see a lot of your injuries, and then also the sacrum and the coccyx, which kind of gives way to the tailbone there. Some other components of the spine that I think are very important for your practice, because these are sort of some of the elements where a lot of injuries take place. So the first component that I want to talk about is called the vertebral body. This is a large segment of bone that's on that is at the forefront of every vertebral level or level of the spine. So this is going to be this bony segment here. And then in between each bony segment, you have the disc, and it acts as a shock absorber, for all of our movements, but particularly in high impact injuries. And they take a lot of the brunt of that impact to the spine. And particularly, I want you to note the end plates. So the end plates are the portions of the bone here that are just above and just below the disc. And I'll tell you a little bit later why those are important. The neural foramen is literally just a fancy term for the hole here where the nerve passes through. And that's important because it is crowded by bone here and then disc on this side as well. And the facet joints. These are just the joints that interlock each segment of the spine to allow everything to move in unison. So some common spinal injuries and conditions that you're likely to come across in practice, and I'm sure see on a very regular basis, are going to be categorized in a few different ways. So in disc injuries, and I'll go over this in the next slide a little bit more, but you have sort of a spectrum of disc injuries that you can have, ranging from least severe to most severe. So you'll have disc bulges, protrusions, and herniations, and you can also have sequestered discs or pieces of a herniated disc that have actually broken off from the main component of the disc. For fractures, you can have acute versus chronic, and acute just basically means new, and chronic obviously meaning old. And you can also have compression fractures, which you'll see often in injuries as well. I'll show you what that looks like in a couple of slides from here, but essentially that's just when the vertebral body is compressed down due to an axial load placed on the spine or a direct impact to the back. So you'll see these in high velocity motor vehicle accidents, or where a large force is, fallen even onto the person's head. I had a patient actually who was a construction worker who got hit with a large metal beam in the head and the neck, and actually developed a compression fracture in his low back or lumbar spine as a result. And then the third sort of category that you have here is degeneration, or basically just arthritis. Spondylosis is a term that you're going to see come up a lot in medical documentation and radiology reports. And essentially, it just means degeneration or arthritis in the spine specifically. So to sort of elaborate on the disc injuries that we just talked about, these are some diagrams. This is the part of the vertebrae that you're kind of looking down from the top on. So you're gonna see the vertebral body is not shown here because it's showing you the disc that's in between, but you'll see sort of the spinal canal here, and then also the spinous process and all of the other bony sort of components there. But this is a nice, normal, very happy disc. This is a protruded disc. So you'll see the material from inside is bulged out a little bit. A disc protrusion and a disc bulge can kind of be used synonymously and interchangeably. A bulge can mean that it is bulged out on one side, or it can be a diffuse disc bulge, which means it's bulged out sort of circumferentially here. An extrusion is when that is completely herniated out. Some of this material you'll see is coming out of its casing. And that's when it really irritates the nerve that passes through. And you can see sort of this nerve is a little bit red and irritated here from being compressed by the disc. And finally, a sequestered disc is going to be when it completely is extruded out of its casing. And it is, in some cases, it can migrate and actually mimic pain from a different level. So the compression fracture that we just spoke about, this is actually a CT or a CAT scan of a compression fracture. So if you picture something like a Coke can, just crushing it straight down, that's exactly what happens in a compression fracture. So this is a pretty severe case with what's called retropulsion, meaning some of that bone has actually been shot back into what's called the spinal canal here, and the spinal cord is located there. So that's a pretty significant injury. So to break things up, these are a couple of fun pictures. These are two pictures of me in the operating room, just to kind of demonstrate a little bit of what I do. So here I am inserting screws for a lumbar spinal fusion. And then here I'm just closing up a surgical wound after the case is done. So very intimately involved in all parts of client and patient care from a neurosurgical standpoint. So next I want to go over some physical exam findings. And obviously this is not by any means going to be comprehensive, but these are some things that I think are incredibly important to look for and to have in your documentation when you're, kind of comprehensively representing a case and your client. The reason being because some of these are representative of underlying abnormalities, right? And some of them are recognized by the Workers' Compensation Board, at least in the state of New York, and are actually used in grading for permanent disability. So they're certainly recognized in the legal world, and they're almost, I don't want to say easy points, but if they're present in your client and your patient, they're certainly not something that you want to miss documentation on. Sorry, I'm going to go back first. Range of motion is actually the first thing that I want to talk about. So range of motion would be involving the neck and the cervical spine and also the lower back, the lumbar spine. After a motor vehicle accident, muscle spasm can limit range of motion, but so can underlying abnormalities like nerve compression. So that's certainly something that I always test and look for. And something that I think should be in every physical exam and medical record, especially pertaining to spinal injuries. The next thing that we're going to talk about is isolated muscle group strength testing and sensory testing. So it is incredibly important to isolate muscle groups whenever you are doing a physical exam for a spinal injury. The reason being is that every segment of the spine, and you can see it as we go down here, every segment of the spine has a different nerve that comes out in between segments. And each of those nerves go to a different portion of the body. They control a different muscle group, and they also provide sensation to that area. So this is a map of sort of everywhere that nerve that's labeled here provides. So if you have someone coming in with weakness in their bicep, you are it is much easier to be able to sort of link abnormalities on an MRI to an injury whenever you're able to document that injury caused the weakness or the sensory changes. Same thing with dermatomes, which is just the fancy term for this sort of map that helps you tease out sensory changes. So someone may come in with numbness, they may come in with pain, but all of that is incredibly important to tease out and document. So if you have medical records from a spine provider that just say that your client moves their arms and legs, that's unfortunately not good enough, and it's not going to be good enough to help provide a really strong case for you. The next two things that I want to talk about are called tension and compression signs. And these two things are actually acknowledged by the Workers' Compensation Board, among other things. But the first one is Sperling sign. So Sperling sign essentially can reproduce a client or a patient's neck pain and arm pain as it relates to a disc herniation or some compression in their neck. So essentially, you place the patient in a position where they're already encroaching on that nerve that's already injured and compressed, and you're reproducing that pain. And a positive sign is actually not so great because you're reproducing their pain, but it's important to document that it's there on examination because it helps you link those things in the physical exam realm, but also on the MRI and their injury. Straight leg raise is the same thing. So you have the patient lie on their back, you lift one of their legs, that increases tension on their sciatic nerve, which runs along the back here. If that patient already has a disc herniation or an injury that's inflamed that nerve, you're not going to be able to get very far with the straight leg raise before they start reporting pain. So it's important to not only document that it's present or a positive finding, but you also want to document the degrees at which they reported symptoms. Okay, so the next thing I want to talk about are reflexes. You have deep tendon reflexes, which are the ones that all of our doctors test when we go to the doctor's office with a reflex hammer. They hit your knee, they might hit the back of your foot, they might test a couple places in the arm. Any abnormalities in these reflexes, whether they are heightened or depressed, can be indicative of neurologic dysfunction. That it's a it's a little bit generic, so it's not exactly specific to a region, but it's still important to document because you want to document as many of these abnormalities that this patient may have as related to their injury as possible. The Hoffman's reflex is the next reflex that I want to talk about. This is sort of regionalized to the cervical spine or the neck. So if you have a patient that comes in with a neck injury and a large disc herniation in their cervical spine, they may or may not have this abnormal reflex that may indicate cervical cord compression or spinal cord compression in their neck. The next and last one is clonus. So this typically involves examining the foot and assessing whether or not they have what's called beats of clonus. It's kind of a feedback mechanism, and the whole mechanism of why it's present and how it happens is not fully understood. But when clonus is present, it is an abnormal finding and may be indicative of neurologic dysfunction as well, combined with other findings. So all three of these are incredibly important to document and test for in every patient. All right, so moving on a little bit, I picked out some buzzwords that I think are incredibly important and ones that I have spoken about to attorneys that I work with, because when you're going through a mountain of paperwork on a personal injury client, and it's a bunch of words that you've never seen before, you don't even understand the meaning, you really want to be able to breeze through those and pick out buzzwords to know if your client has a significant injury and needs to be referred to a specialist. So things that I have found are kind of easy to detect, by quickly reading over something, a radiography report. First, I'll start with MRIs. So things that I think are valuable to look for, anything that says T2 hyperintensity or hyperintensities on T2. The reason being is because T2 is a sequence on MRI. So on a T2 sequence, you're going to see water and fluid as bright white. And what happens in the setting of inflammation and swelling and edema, fluid goes to that space. That is usually, not always, but can be indicative of an acute or a new injury. So right then and there, when you see something like that, you know that there's something new on the MRI that may or may not have been there before. Stir changes is the next one. Stir is another sequence on the MRI and is usually utilized whenever you're evaluating a compression fracture. So if they have stir changes on the MRI in the setting of a compression fracture, it doesn't necessarily 100% of the time mean that it is related to this injury, but it can indicate that it's a relatively new fracture. In-plate edema and modic changes are the next thing that I want to talk about. So remember when we pointed out the in plates on the anatomy slide, that's why I said this is important. So if they note modic changes or in plate edema, those in plates will get very inflamed in the setting of an acute or a new disc herniation, especially in the setting of an injury. I see these all the time with motor vehicle accidents and high-speed accidents when they have a very large and new disc herniation as a result, and you've got those in plate changes. That tells you that that is a new injury and not something that has been there for a long time. An annular tear is another thing that is really helpful to see when you're looking at reports. So that just means that there's a tear in the disc and that disc is compromised, and you're likely to have a herniation or something to go along with it. So when you see that, it doesn't necessarily mean that it's related to the injury, but there is definitely injury there. And compression. So on an MRI, you're able to see discs, you're able to see nerves and tissue much better than you would be on a CT scan. You're not really able to see the neural elements at all in a CAT scan, but you can see the discs. Sometimes you just get a much better picture of that on an MRI. Moving on to an X-ray. X-rays, you're going to be looking for fractures. You're going to look for, you can see some degenerative changes. You can see loss of disc height. So if you see, you can see bone on X-ray basically. So if you see that two levels of the spine are very close together, that disc really, all of that disc is either herniated out or it's lost hydration and is injured. So that may be indicative of a further injury, and you may want to refer them out to get a further workup, whether it's with an MRI or a CAT scan. A CAT scan is really great for evaluating fractures. So again, that compression fracture that I showed you guys earlier, that was on a CAT scan. Very, very good to evaluate fractures with. You can also see arthritis on a CAT scan, and also something, different radiologists use different terms for this, but calcification. So if you see a fracture on a CAT scan, but it is calcified, it's possible that that fracture is not new because that fracture has developed calcifications during the healing process, and it is somewhat healed already. Okay, so now we are going to tie in everything that we just talked about in a nice, pretty box with a bow on top in a sample case that I made up. So let's say you have a 55-year-old male that, let's just say he's got pre-existing neck pain. We know that he has arthritis in his neck. He might have some disc bulges and herniations. He's been to the chiropractor and, getting injections and taking oregano oil for it. Okay, so he has a pre-existing condition, we know that, but he presents following a motor vehicle accident. He comes in, he's got arm pain, weakness, and he's got some difficulty walking. He's got balance problems, and his symptoms, all of this started 3 days after the accident. He's definitely got neck pain, but he had neck pain before and now it's worse. Okay. Sorry, guys. Okay, so on physical exam, this is by no means comprehensive, but this is just very shortened for the purpose of this presentation. On physical exam, muscle group examination shows or reveals that his deltoid, his ability to lift the arm here, is only a 4- out of 5. And that means that he's able to apply very little resistance to your strength. So he's able to get it out above gravity and apply a little bit of force against you, but by no means is he at his baseline or his norm. He demonstrates a positive Sperling sign on exam and a positive Hoffman's reflex on the right side. And he's unable to perform what's called a tandem gait. So this is the kind of walking that you do when you get pulled over. Okay, so this is walking one foot in front of the other. He's not able to do that. Okay, so this gentleman was referred for an MRI. His MRI shows, let me move you over a little bit. So his MRI demonstrates degenerative changes. Okay, this is no surprise to anybody. We know he's been seeing a chiropractor. We know he's been doing tons of other types of treatments for this. We know that he's probably got some sort of pre-existing condition, and he may even have another MRI, maybe from a year ago or something. Okay, so his MRI here shows disc herniations at multiple levels. Most significant, though, is noted at this level here, which is C2, 3, 4, 5. Okay, so he's got pretty significant compression here. And we know this because, do you see these 2 white lines that kind of come along the back and the front here, and then the black line in between? So the white lines are fluid. This fluid kind of bathes and coats and protects our spinal cord, which is the black line here. And then we see the vertebral bodies here and the discs that go in between them. So when we're looking at this, we see that this is pretty nice and open here, but then when you kind of get up here, it's looking a little tight. You can see the spinal cord is kinked, not a whole lot of room. And then you get here and this looks pretty bad. So on the axial view, or the top looking down view here, you can see, and I'll show you this compared to a diagram, so it's a little bit easier to see, but you can see how there's this black circle here, and there's a little bit of a black divot that comes out here. This is his disc herniation, and this is compressing his nerve. So the nerve, this is the spinal cord here in the middle, and then as we sort of branch out here, the nerves sort of come out on both sides, and it's pretty tight here on this side as well, but we can really see that it's smashed here on the other side. Per radiology report, he has a right paracentral disc herniation resulting in severe central canal stenosis, this being the central canal displacement of the thecal sac, which just means that the spinal cord and its elements have been displaced and shoved over by this herniation. And severe neural foraminal stenosis. So he has severe tightness of the neural foramen, which is the hole that the nerve passes through. and he has associated cord signal change. So this is going to be noted as a T2 hyperintensity. Do you see how there's this little bit of white within the cord here? This is from his injury. And this is from a cord injury from this disc herniation. Okay, so just to demonstrate this a little bit better, and so here you can see the backbony elements here, and you also see that here, right? And then right here, you have the spinal cord in the middle, and you've got it here as well. And this guy is going over to the other side, but you can kind of appreciate how the disc would be here, and that herniation is just pulled out over here. Okay. So that, that really ties in everything. And I hope that demonstrates how important it is to be thorough in your physical exam, thorough in your workup, but also being able to recognize some of these terms in a radiology report or otherwise can really help you in determining where your client needs to be seen, and, what you need to look for in your case. An expert witness can certainly help you with that, along, with a seasoned and well-practiced provider. But an expert can help you provide, as you know, impartial and credible opinion. They can help you make informed decisions on causation and severity, and also sequelae. So what is life going to look like for our gentleman that we just spoke about? He may go on to have surgery, but that doesn't mean that his deficits are going to be gone right after surgery happens. Let's say his occupation requires him to lift heavy. Let's say he's a mechanic. Abnormalities like what was shown on his cervical spine MRI are going to lead to dexterity issues in his hands. He probably has difficulty using his hands, holding tools, carrying things. He can hardly even walk on physical exam. So none of these things are going to get completely better the day after surgery. These are good. This is going to take weeks and months of rehabilitation, and unfortunately, this is going to put him out of work for quite a while. So an expert can also help you with assessment of pre-existing conditions, right? So this gentleman already had arthritis and a significant number of disc herniations, probably that have been around for a while. But they can help you to kind of tease out the new components of that and what portion is an injury and maybe what portion isn't. They can also help you to quantify subjective variables. So using grading scales, pain grading scales, using things like the reflexes. It's much better and much more solid to use things like this to help sort of quantify a client's injury as opposed to just saying they're in a lot of pain, right? So you really want someone who can demonstrate in a comprehensive manner your client's picture, not only, for your purposes, for the court, but for your client. Okay, so with that being said, I'm kind of going to open the floor to questions. Feel free to drop any in the chat, and Amy, if you have some, please
So
send
drop it into the question and answer because the chat is disabled.
Oh,
So so yeah, we have the first question is, can you explain the difference? Someone wants to know between spondylosis and spondylolisthesis. I can't say it.
Yes, sure. I would love to. So spondylosis is kind of a sort of a fancy term for, arthritis in the spine, right? You're going to see that on nearly every radiology report that you get, and anybody over, 50. So everybody's going to have some component of spondylosis. Spondylolisthesis is when you have a slip in the bone. So when you have two segments or three of, let's just say, the lumbar spine. So the radiology report may say grade 1 spondylolisthesis of L4 on L5. That means that L4 has slipped forward on top of L5. This creates a problem because it pinches all of the elements that are in between L4 and L5. It makes the disc herniation potentially worse. It further impinges upon the nerve, and it creates a lot of pain in the joints that are trying to hold everything together. So with that, you probably want to refer them for what's called dynamic x-rays, where they're bending and extending to make sure that isn't wobbly while they move.
Okay, great. I also was wondering if you could just demonstrate what the Hoffman sign and what clonus kind of looks like.
Sure. I wish I had
You could just do it with your
a
fingers.
poor victim in the audience that I could pull out so to demonstrate it. Well, clonus is I'm not going to demonstrate clonus because it's on the foot, but I will do it with Hoffman's, and I'll kind of try to demonstrate clonus with my. So Hoffman's reflex is when you kind of you're flexing the middle finger on the patient, and then you're flicking their middle nail. Now, when that happens and somebody has cervical cord abnormalities or compression, these two fingers, the index finger and the thumb, are going to come together involuntarily. And that is an abnormal finding. And if the patient has no imaging, you're going to want to get some imaging on them to see where this is coming from.
Great. And then the next question from Dennis Smith is, what is the significance of lordosis?
Sure. So lordosis is a term that is used for normal curvature of the lumbar spine. So you're going to see all the time in in radiology reports loss of lordosis. So a loss of lordosis can be present in a couple of contexts. So in one context, it can be present in arthritis. As the spine degenerates, it tends to lose that normal curve, which kind of is a little bit of a convexity. So it tends to sort of straighten out. But also you can see loss of lordosis in muscle spasm as it relates to a new injury. So there's a couple of ways that you can look at it. You're usually, the best way to determine that is to get a standing x-ray to really get an idea of what the patient or the client's natural curve looks like while they're bearing weight, because on an MRI and a CAT scan, they're lying down.
All right. And Thomas Bond wants to know, is a herniation without nerve root impingement an innocuous finding?
No, it's not. So it depends completely on the patient's presentation and how your client feels. I will say that if you show an MRI to 5 different spine specialists, you're going to get 5 different opinions on it. Not widely ranging, but I would still say if you have a contact or you have an expert that you can touch base with to review the imaging, I would still have it looked at because, there's many ways to look at disc herniations, particularly on something like an MRI. It can be encroaching on the nerve. It can be, if facing the thecal sac and things like that. And it doesn't mean that it doesn't cause problems. I have had plenty of patients that haven't had the most severe herniation. But what can happen is in the impact of injury, that herniation can come out much further and then retreat back a little bit. So it doesn't mean that what you see on the MRI is sort of the punch that the nerve is taking per se. So in the moment of the accident, that nerve can still be injured and very inflamed from the herniation itself.
We have a question here. Have you dealt with paraplegia or tetraplegia?
Yes.
with caused by personal injury, like accidents?
Yeah, 100%. I mean, that is an incredibly unfortunate, consequence of some very severe injuries. So you're talking about, complete and total spinal cord injury, either in the cervical spine or the thoracic spine, depending if you're talking about quadriplegia or paraplegia. But yes, absolutely. We unfortunately see it in the setting of trauma, and I've seen it a lot in the ER and in the ICU.
Yeah. Okay. I have more questions about that the attorney didn't ask, so I won't ask. I happen to have insider information on that one. Okay. Here's another one. Typical defense will cite a treatment record containing the term spondylosis and claim that this means it was naturally caused by normal aging degenerative arthritic condition. Is this not an incorrect interpretation? as the existence of spondylosis can be consistent with a trauma-caused vertebral disc injury?
These are the arguments that I love. You know? So exactly what I'm talking about with pre-existing conditions. So oftentimes what I have seen is in a defense, they will say, oh, well, you know, it says spondylosis on here. So he had all of these things before. You could easily make the argument for our gentleman, you know, our 55-year-old gentleman, but that's what I mean when I say that it's so important to have, you know, a good expert on your side. Because yes, a lot of that were spondylotic changes. And you can tell that that didn't occur yesterday. And certainly not at the accident, because there's just certain things that, you know, experts and medical professionals can see on imaging, that, you know, help you determine that. However, just because a client or a patient has spondylosis does not mean that they do not have an acute injury or disc herniation on top of that. You can have both. They are not, you know, mutually exclusive entities. So you can absolutely still make the argument that there is an injury present with or without spondylosis present.
Perfect. And can you talk a little bit about the presence of disc disease in like normal population? Because that's something as a primary care doctor we hear a lot about.
Yeah, all the time, I'm sure. Yes, absolutely. I mean, listen, degenerative disc disease is, you know, the hot term for it. You're gonna see that left and right again once your client population reaches a certain age. You're gonna have tons of pre-existing conditions in the spine. You know, it just so happens that a lot of people complain of pain there, so they get imaging, and so you see it. But it doesn't discount really any injury from happening or being appreciated in those areas as well. But yeah, so I mean, as we all age, you know, just to speak on your point, Amy, as we all age, we lose water. You know, our hydration, our generalized hydration all over our bodies is less as we age. The discs in our back are made up of partially water. So when you're losing that hydration, you lose hydration there as well. And your discs over time lose the ability to provide all of that shock absorption that they're meant to.
I think that's also like why having someone like you is so important, because you can tease out what of this was. It's just important to have someone to say what was pre-existing and what is new, and
Yes.
having an exam that with somebody that knows what the heck they're doing is really important.
Yes, definitely important. Vital.
Okay. I don't think we have any more questions. I'm just going to give a moment for anybody else who has last minute questions. But then we're going to just move on to the bonuses that I promised you. So I think we're going to move on.
Yeah,
thank you. Thank you so much, Randi. That was amazing. And as you guys can see, like how amazing she is. She's just great. And I'm really, really so blessed that she was able to give that presentation to us today. So thank you. We're getting a lot of thumbs up from from the people that are watching.
Well, thank you so much, everybody, for joining.
And you can reach out directly to Randi with any questions that you have. I put those links in the chat, but it's the linkedin.com Randi Rasberry. It's like the fruit, but without the P, and then randi.rasberry@gmail.com.
Yes, I know. And please, you know, reach out to me, connect with me on LinkedIn. I know I've already connected with a few of you, which has been an absolute pleasure. But thank you so much for being here and attending.
So don't drop off the call, because I have a couple of free things for you guys at the very end, and we won't take much more time. But I just wanted to tell you that just like Randi, High Rock Experts we have 4,000 amazing experts on our panel that we can help individually match you with. And so if you are looking for an expert witness, contact me. And we're physician owned, and we will work with you to find a really great expert. We've matched over 500 experts and counting to attorneys across the United States. In 2 weeks, we're going to be having another webinar. The next one in the series is going to be Heather Hammerstadt. She's an emergency room physician. She will be speaking, emergency medicine physician. She will be speaking about sepsis, strokes, and trauma. And she'll be talking about it for personal injury attorneys and medical malpractice attorneys. So definitely don't miss. About every month, there will be a new expert presenting for this series. So we really hope that you can attend. Thank you so much.
Awesome.
All right.
Thank you, everybody.
All
We
right.
appreciate your time.
Thank you, everybody. Bye.